This recorded lecture will be going over Chapter 5, Assessment, Data Analysis, Problem Identification, and Planning. Assessment consists of gathering information about patients and their needs using a variety of methods. During the assessment phase of the nursing process, data, which are pieces of information on a specific topic, are systematically obtained and organized into a logical database. This is where all the information can be gathered and stored about a patient, and then documented. Data collection is a large part of the nursing assessment. A registered nurse is designated as the staff who must perform the initial admission assessment for every patient. However, the LPN is often asked to assist with this task and participate in carrying out the plan by continuing to collect data through ongoing assessment. The practice of nursing is concerned with how a patient responds, both physiologically and psychologically, to their disease or disorder, treatments, life situation, and environment. It is in this capacity that LPNs contribute via the data collection to the assessment stage of the nursing process. There are various approaches to data collection. One approach is structured format to obtain a comprehensive database based on the 11 functional health patterns. You can see a great example of this in box 5.1 on page 60. The assessment data is then analyzed by comparing the patient's baselines, like a usual blood pressure, heart rate, weight, and so forth, with our normal baseline values. Analysis and comparisons will help identify any patient's strengths and weaknesses. A second method of data collection is to begin with areas in which problems are evident, like pain. Factors that are causing or affecting the pain should be explored. This is an example of a focused assessment because it's concerned only with one specific problem. The assessment and data collection will then progress to analyzing how the problem affects other areas of the patient's life. A third method is to assess every area in Maslow's hierarchy of basic needs. Whatever method is used, the assessment and data collection must be comprehensive. This means covering all aspects of the patient, including physical, psychosocial, and spiritual. A new admission assessment and data collection interview. This is where you have a conversation and obtain the facts that you need. It's typically performed when patients are assigned to the nursing unit, enter the care of a home health agency, or become residents in a long-term care facility. The nurse interviews the patient to find out their major complaints, performs a physical exam, and determines the patient's overall health status. Data obtained from the patient verbally that only the patient can describe or verify is known as subjective data. An example of such would be a headache, tingling in the feet, or any types of pain. Information obtained through the senses and hands-on physical examination is objective data. Objective data would include signs that are seen, heard, measured, or felt by the person who is carrying out the assessment. Vital signs, physical examination findings, and results of diagnostic tests are all included as objective data. There's a great example of further examples of subjective and objective data on Table 5.1 on page 60. Additional sources of data would include the primary care provider's history and physical exam, any ancillary staff notes, and of course, the admission note. The patient interview is focused on gathering data. Good communication is vital to adequate assessment. Communication could be verbal, talking and listening, or nonverbal, including facial expressions, body posture, movement, and gestures. The interview contains 3 basic stages. The opening, when you establish rapport with your patient, the body of the interview, where necessary questions are presented, and the closing segment of the interview. After establishing rapport, discuss the purpose of the interview. Always thank patients for their time, express concern for their welfare, and tell them what will happen next. Summarize any problems and tell them when you'll be back. Assessment is always an ongoing process. A medical records review is a data collection tool that assists in obtaining the information needed to interview the patient intelligently or to prepare adequately for the day's patient assignment. To do a review in preparation for your clinical assignment, first look at the patient face sheet. Then look at the most current primary care provider's orders. Next, check the orders from the previous 2 days. Next, check the medication profile to see what medications the patient is receiving and when. This can provide information about concurrent chronic conditions that may not be initially evident. Read the primary care provider's admitting, history, and physical assessment notes. Note any psychosocial data on the face sheet. Does the patient live with family or significant other? What support systems do they have? Next, review the nurse's notes from the previous 24 to 48 hours and look up any current diagnostic test results. However, you need to collect data. It's important to do so systematically to obtain a full picture of the patient's problems and needs. The RN will obtain the health history, and they are responsible for the initial physical assessment. However, parts of this assessment can be delegated to the LPN. To conduct the assessment, use techniques of inspection, which is looking, auscultation, which is listening, typically with a stethoscope, palpation, using the hands and sense of touch, and percussion. This is tapping the body with the fingertips to produce any vibrations and sounds. The physical exam will begin with measuring height, weight, and vital signs. Record a history of any medications the patient is currently taking and medication allergies. Take a brief medical history. Ask about any special assistive devices that may be needed, like hearing aids, glasses, a cane, prosthesis, or dentures. Gather a nutrition and skin assessment and note the findings. A risk screening for falls may be required. A determination of educational or discharge planning needs is required so that planning can begin. Conduct a complete physical exam, paying particular attention to any body system in which the patient is expressing a problem. After the admission assessment, each patient should be visited and assessed during the first hour of each shift. Perform your head-to-toe exam, which should take about 10 minutes. Later in the shift, explore particular problem areas for each patient in greater depth by conducting focused assessments. At the time of the initial data collection and assessment, determine what supplies and equipment will be needed for the patient throughout your shift. And this next few slides here, we'll be going over box 5.3, which shows the quick head-to-toe assessment, and it's going to highlight the different areas of that assessment that you would like to focus on. An extensive initial assessment is performed when a patient enters a long-term care facility. Reassessment will be done at fixed intervals and, of course, with any change in the patient's condition. In addition to the physical assessment, a health history and medication history, as well as a functional assessment, will be performed. A functional assessment supplies a picture of the activities of daily living with which the patient might need assistance. Typically, the LPN collects the data for the RN, who then finalizes and validates the assessment. The initial patient assessment in the home is performed by the RN. The nurse must work within the patient and family's territory, and that does require a shift in attitude and perspective as compared with working in a healthcare facility. The LPN, when doing private duty in a home, will perform daily assessments and maintain necessary documentation. Any changes found upon assessment must be reported to the RN supervisor. Cues are pieces of data or information that will influence decisions. Problems must be identified so that problem statements and nursing diagnoses can be synthesized and then written by the RN. The LPN assists with this process. As the database is examined and pieces of data are sorted, related cues will be recognized, grouped or clustered together, and then analyzed. Any missing data will be identified. Formulating a problem statement and nursing diagnosis depends on the nurse's knowledge base and their previous experience. Once patient cues have been identified, they will be grouped together and any inferences or hypotheses can be made about them regarding patient problems. While clustering these patient cues, the nurse should always try to interpret the meaning of those cues. The second step of the nursing process results in the development of a problem statement or nursing diagnosis. A problem statement or nursing diagnosis typically involves three parts: the patient's problem or a potential problem, the causative or related factors, which could include pathophysiology, and specific defining characteristics, or the signs and symptoms. The medical diagnosis is never included in the construction of a problem statement or nursing diagnosis. Whatever terminology you use, the problems that are identified must reflect the nurse's clinical judgment regarding the patient's response to either an actual or potential health problem, and this will be the basis for a nurse's care plan for the patient. This textbook and related books within this series will use a priority problem list. You can check this out in the back cover of the book. The term problem statement will be used in future discussions for patient problems. Once problem statements are identified, the planning phase occurs. It is acceptable to use standard abbreviations for problem statements. For example, pain, RT, that means related to, right ankle injury, AEB, that means as evidenced by discomfort and swelling. We'll get a lot more practice with that in the clinical setting. Etiologic factors are the cause of the problem. These are often the result of some pathophysiology. Defining characteristics include those characteristics or signs and symptoms that must be present for a particular problem statement to be appropriate for that patient. These essentially supply the evidence that the problem is actually valid. Signs are abnormalities that can be verified by a repeat exam and are considered objective data. A bruise on the arm would be considered a sign. Symptoms are factors that the patient has said are occurring, and they cannot necessarily be verified with examination. Symptoms are considered subjective data. A headache would be considered a symptom. You can't see or verify that your patient has a headache, so you must trust what they tell you. Problem statements and nursing diagnoses will differ from the medical diagnoses because the nursing diagnosis defines a patient's response to illness, whereas the medical diagnosis labels that illness. Priorities of care are set so that the most important interventions for the high priority problems for each patient must be attended to first. Once the problem statements have been formulated, they will be ranked according to importance. This order can be guided by hierarchy of needs adapted from Maslow. That can also be guided by the patient's beliefs regarding the importance of each problem and by what is most life-threatening or problematic for the patient. Physiologic needs for basic survival will always take precedence. Airway always comes first. ABC. Airway, breathing, circulation. Circulation is the next priority. After a nurse consults with and involves the patient in determining priority of needs. After physiologic needs have been met, next, the safety problems must take priority. Nursing judgment is crucial in setting patient priorities. Critical thinking is necessary to make astute clinical judgments regarding your patient's priorities. After physiologic and safety needs have been met, the psychosocial needs of love and belonging, self-esteem, and self-actualization can be given attention. Every nurse should attempt to look at the patient holistically, keeping any psychosocial needs in mind and working on physical problems. In a long-term care facility, the care planning process begins when a patient is admitted, often by the LPN. The supervising RN reviews the care plan, modifies it as needed, and finalizes it for the medical record. Problem statements in the home health care setting must include any problems identified in the family's ability to cope with the illness or situation, and of course, patient education needs. A goal is a broad idea of what is to be achieved through nursing intervention. Short-term goals should be achievable within 7 to 10 days, whereas long-term goals could take weeks or months to achieve. Long-term goals will often relate to rehabilitation. Questions that the nurse should consider in part of the planning process include: what are the goals for my patient? How can they be expressed as outcomes so the success of nursing care can be easily evaluated? Should the goals for this patient be short and long-term? What are the priorities of care? Goals will be formulated and converted into expected outcomes, and interventions must be chosen. Expected outcomes will be derived directly from goals. An expected outcome is a specific statement regarding the goal the patient is expected to achieve due to the nursing intervention. The expected outcome should also contain measurable criteria that can be evaluated to see whether the outcome has been achieved. An expected outcome should always be realistic, attainable, and have a defined timeline. The patient and other health professionals involved in the patient's care must all agree on the importance of the expected outcome. Some health facilities will use the term discharge criteria in place of expected outcome. Desired outcome is another term that can be used for this. The planning process in long-term care facilities is the same for any other facility. In the home health care setting, nurses will collaborate with family members concerned with the care of the patient when choosing any expected outcomes. The nurse must select appropriate nursing interventions to alleviate the problems and assist the patient in achieving their expected outcomes. Questions to consider when choosing a nursing intervention should include what nursing actions are necessary to monitor the status of a high-risk problem. Which nursing interventions can best help the patient reach the expected outcomes? What nursing interventions could possibly prevent a potential problem from becoming an actual problem? Which interventions require an order from a primary care provider? Which interventions fall within our licensure to practice? And what is the specific rationale for each intervention? Interventions listed should include giving medications and performing ordered treatments. The nursing care plan is initiated by an RN through the LPN, though the LPN often helps construct the plan of care, which is ultimately approved by the RN. The nurse can change or modify outcomes and interventions to individualize the plan. Once the entire plan has been created, it will then be reviewed and placed within the medical record. The nursing care plan should be constructed right after the admission database has been collected. Once every 24 hours, the care plan must be reviewed and updated.